Well, it really depends upon what population you're talking about. And I go back to the data that we know from the Scholar 1 data, which looked at patients who were refractory to their frontline therapy or refractory to second-line therapy, or those who had recurred within 12 months of an autologous stem cell transplant. And this was to quote this, or to cite this paper, this was a very large study looking at the relapsed refractory diffuse large B-cell lymphoma, population. And it was pretty sobering. 636 patients were involved in this study, taken from clinical trials as well as retrospective cohorts. And within that cohorts of patients, of all three that I stated, which were pretty high-risk large cell lymphoma populations, we were looking at therapies which had overall response rates in the 20%, complete remission rates less than 10%, median overall survival around 6 months. So kind of signaling that this is an unmet medical need. You have to stare a patient in the eyes and tell them, in 2 years, only 1 out of 5 patients are alive that were in that study. That's a big deal. And that's where we have to kind of, I think we're really striving to improve therapies in that patient population, but I think in relapsed refractory large cell lymphoma in general. In the heavily pretreated diffuse large B-cell lymphoma population, so I would consider that somebody that has received frontline therapy, second-line therapy, especially if they were able to go on to get an autologous stem cell transplant and their lymphoma has come back, namely their diffuse large B-cell lymphoma has come back, because retrograde transformations can occur post-transplant or or in the relapse setting. So you want to be mindful that you have a biopsy that still says diffuse large B-cell lymphoma, because if it doesn't, then your treatment paradigms may change and your treatment options may differ in that setting. But in that heavily pretreated diffuse large B-cell lymphoma population, we're really living in a lot of single-arm phase 2 studies, studies which have accrued 20 to 30 patients and really demonstrated overall response rates, which at best are living in the 20 to 30% range. But even with that, there appeared to be very little durability with those responses. And so really we are looking for better therapies in the relapsed refractory diffuse large B-cell lymphoma spectrum. Now, to give pause into what's a common control that can be used in, if you will, in a randomized fashion in the relapsed refractory large cell lymphoma study, I'd like to call out a study that was presented at ASH in 2017 by Dr. Lori Sen and colleagues, looking at specifically at the control arm, which was bendamustine and rituximab, which took patients who had relapsed refractory diffuse large B-cell lymphoma and gave them a common regimen that I, in my practice, use, which is bendamustine and rituximab. And really, it was quite, again, results that were sobering in the diffuse large B-cell lymphoma relapsed refractory setting, with 20% overall response rate. Median overall survival on that study in the control arm was 4.7 months. A lot of the patients couldn't even get through several months of therapy, either because of toxicity or because their disease was just progressing through that chemotherapy. And that's a common chemotherapy that we have in the compendium listing for use in relapsed refractory diffuse large B-cell lymphoma. Now there are others. There's data that shows that ibrutinib or lenalidomide may have and may derive benefit. I have used those in the relapsed refractory diffuse large B-cell lymphoma setting. But again, you're always, in those oral therapies, you're really kind of looking for what percentage of them, and it's going to be less than 50% that are going to respond. And then you're really hoping for some durability.